Good evening, everyone. Today's topic for the class is Overview of Refractive Surgery. Myself, Dr. Sivaranjani. Moderator for this class is Dr. R.R. Sudhir, sir.
Yeah, just before we start, this is basically a practical class just to know the different refractive surgeries that we perform, okay, and how to choose a patient for that. When the patient comes, what are the indications and what are the basic evaluations you do. And we also will have a live demo of EMR. We'll show you the case sheet. You can decide what surgery you will perform for that patient. Okay, so everybody at the end of the class, each one will get a choice to go through the case sheet and suggest what your things are. So it is just at the end of the class, you should know what are the checklists you need to look for and whether you can suggest the patient a refractive surgery and what refractive surgery you want to suggest. And there are a lot of mental calculations we need to do. So some max is there involved into this. So be active and keep your pens, or if you have excellent mental max you can do it. Okay, let's see how things go on. Okay, so let's start. We'll have a just first overview because you need to know what are the indications for each procedure, what are the things. So the first part of the session will be on the overview, then we'll have how to evaluate a patient, and then we have a live scenarios, and then we end the class. Okay, go ahead, ma'am.
So, refractive surgery is a subfield in ophthalmology. Here, surgical correction of refractive errors of human eye is being done. It is
Just we'll
broadly.
just stop here once for the first years. So if you are doing a medical management of a refractive power, what are the options you have for the patient? We can have for a medical management of refractive. Here, this is all on refractive surgery. So before you suggest a surgery, so you have to give all the options to the patient. No, if they exhausted, then they come to refractive surgery. So what and all the procedures or things you think of?
Spectacles, sir,
Yeah.
and contact lenses.
Okay. What else? If you tell the third one, you get that. Second, yes, any one of you? What is the third option you can think of in not in all scenarios, but in certain scenarios, yes.
The refractive surgery.
Before refract, I said medical management. We're not treating the patient with any surgical procedure.
Atropine eye drops.
Tropin, how can I tropin? So we'll give it to general ophthal fellows. We'll go step by step. Okay, it's open to the cornea fellows now. So I'll give you a clue. The patient wears it at night. In the morning, they have clear vision. Uh, so you have the option of the orthokeratology. So these are the three options which are medical management. So now we look on to the refractive surgery and what are the options? Well,
Broadly classified into cornea-based and lens-based procedures. Cornea-based procedures are incisional, whereas radial keratotomy, laser ablation includes photorefractive keratectomy, LASIK, Epi-LASIK, LASIK, SMILE, conductive keratoplasty, corneal inlay and rings. Lens-based procedures include clear lens extraction and phakic IOL. Here,
just go
indications.
back. You have missed the other one.
Combination of two can also be tried.
Okay. So again, we'll start with first years. When do you think of using refractive surgery? So we start with medical management. So the patient doesn't want to wear contact lens, doesn't want to wear spectacles. So now we come to refractive surgery. So what is the one indication before you say yes, you can go ahead with the procedure?
Anatomically the eye should be normal.
Mm-hmm. Any of the second years? Very simple one. So I have, yeah, stable refractive error. Okay, so we have laser-based procedures, we have lens-based procedures, then we have a combined procedures. Have you heard of it? So when is the indication for combined procedure? Anyone? Group then.
When we cannot correct it completely based on the cornea procedures, when the error is too high, so we cannot ablate that much. So we would do that and then do a lenticular based thing as well, like a
Okay,
phakic
so
IOL.
yeah, so when the power is very high, so we have the phakic IOL combined with a laser-based procedure, which is the bioptics. Okay, fine.
Indications for refractive surgery. Mainly, there will be unwillingness to wear glass and contact lens. This is the most important indication for going for refractive surgery. and cosmesis, anisometropia, occupational preference. Moving on to the surgeries in detail. Photorefractive keratectomy, here superficial epithelial cells of about 550 microns is removed, stroma is exposed, then laser is applied. Here the vision improves after 4 to 7 days. Here the patient has a longer recovery period and the results are similar to LASIK. Moving on to LASIK, laser assisted in situ
Just
keratomy.
one. So what are the ways in which you can remove the epithelium? Again, we'll give it to second years first.
Manual debridement with a buckle knife.
Give it to the other person next way. Yeah.
Sir, with alcohol,
Mm-hmm. Next.
sir, excimer laser can also be used.
What is it called? Gevophilos? Yes, excimer laser can be used too. So what is that type of laser it is called?
Ablations.
So it is PTK, phototherapeutic keratectomy. So you can remove using that. So what is the and we can also, there are a lot of other types of brushes to use to remove them. Okay. And one more is, it's not microkeratome, it is epikeratome. Epikeratome, removing the only epithelium. So that is epikeratome. Okay. So that's why do we need to use all these procedures? Any of the cornea fellows? When you remove the epithelium, what is the goal of removing it?
The laser delivery is done on the stromal bed, so we want that stroma to be treated, the anterior stroma. So that's why we remove the
So what and all layers you are removing?
epithelium we are removing
Oh.
and
What are the layers of cornea? Epithelium?
Bowman's stroma
Yeah, so where is the actual removal happens? Between?
between the epithelium and Bowman's.
What layer of epithelium?
Basement membrane. Okay.
Okay, you're trying to remove the basement membrane, exposing the Bowman's layer. So if you have seen the procedure, you can see a very shiny surface. That is the Bowman's layer. So you should not. So any patient or anybody, you have a corneal ablation, you have epithelial defect, or you had an ulcer. So when do you get a scar? So again,
When
it's
Bowman
very
membrane is
important.
breached.
Huh?
When Bowman's membrane is breached or it is injured, then we get the scarring.
Yeah. So here you're breaching the Bowman's layer. So you're ablating the Bowman's layer, you're ablating the stroma. So what is happening? So you can cause a scar, correct? So how do you reduce the scar? So that's important with the photorefractive cataract. Second, yes, we'll have. So what are the things we need to look in to take precautions to not to cause a scar?
Mitomycin.
Before that, the surface should be smooth. Okay, so you should not damage this surface, or when you remove it, it should be even, and the entire basement membrane, the separation should happen smoothly, so that at the Bowman's layer, the smooth layer is there. So the laser is also so perfect, it creates a nice uniform plane. Okay, so when it is uniform, it will not cause. The second thing is, as you said, it's a use of mitomycin to reduce the fibroblast proliferation. So reducing the haze. Okay. So this is the problem with photorefractive keratectomy.
Here in LASIK, laser ablation of corneal stroma beneath the hinged corneal flap is created with a mechanical keratome or with a femtosecond laser. Two types of laser are used. Excimer laser is used for corneal stromal ablation. Femtosecond laser, it is used for flap creation. Then it is called femtolasic. Microkeratome is a mechanical method and femtosecond is a laser method. Here, microkeratome highly sharpened blade is used. It can be used in eyes with corneal scar. Femtosecond has advantage that flap can be customized, precise depth control will be there, precise flap dimension and location can be calculated, flap can be centered intraoperatively, and it decreases the complications associated with microkeratome, that is free cap, buttonhole, and epithelial defects.
Okay. So what is the difference between PTK and microkeratome? The LASIK. Where does the ablation occur?
In LASIK, we'll be raising a flap at the level of the anterior stroma, epithelium, Bowman's, and anterior stroma. That's where we'll ablate.
So the Bowman's layer is intact. So you don't have haze. Okay. So we are looking at all the basic small points which you should get into your mind. Basically, we are trying for the first, second years, and for you people. So we don't want to disturb the basement, the Bowman's layer. Okay. So the procedures are, you have microkeratome and femtosecond laser. So we are not going to types of flap, the difference between the different types of flaps, which is again we can deal it in different class on LASIK or microkeratome based. The only thing which you need to keep in mind is the complications associated with microkeratome. So where do you get buttonhole? Where do you get free cap? Cornea fellows?
Flat cornea is free cap, whereas a steep cornea will cause a buttonhole.
So anybody can explain the mechanism of why does we get a free cap in the flat cornea? And flat cornea, what is the cutoff for flat corneas?
The 30.
34. You won't even do the procedure.
40.
Anything less than 40 or close to 40, the cornea is very flat. Okay, so you need to get a hinge. So when it is flat, what happens when the microkeratome runs through? It can run fully. So which is a free cap. So what is the mechanism of buttonhole? Where do you get buttonhole?
Very steep.
Mm-hmm.
When you are creating the flap, like when the vacuum is created in the femtosecond or the in femto-LASIK or with the microkeratome, sir, it causes a indentation. So because of the steepness, the center part of the cornea, there can be a buttonhole in the flap.
Mm. So what happens when the cornea is steep? When you put a microkeratome, the cornea is bulges up, correct? So now we are indenting we are cutting it. So there is a indentation of the apex of the cornea, as a result of which initially you will have a good flap, because whenever there is indented, it will cut through fully and then go through. So that's why you get a central buttonhole. Okay, so these are complications associated with microkeratome. So whenever there is a steep cornea, so what is steep cornea? How much K? So more than 47. So all these basic things you keep in mind. 40, 47, the steep cornea. So whenever you are looking at keratometry, when the patient comes in, you have to keep all these in mind, and then based on that you have to suggest. So I would not suggest microkeratome based procedure when it is steep cornea or a flat cornea. So I would suggest femtosecond laser. Why? Because there is no indentation. The laser goes and cuts underneath it. Okay, so there is no mechanical cut. So you don't get a buttonhole or a free cap. There may be epithelial defects because of the indentation. That's happens in both the procedures. Okay, go ahead.
Patient selection for LASIK includes age should be more than 18 years, stable refraction for at least 1 year, myopia up
It's
to
6 months to 1 year. Okay.
myopia up to 12 diopters can be corrected with LASIK, hyperopic up to 6 diopters, astigmatism up to 6 diopters can be corrected. Here, the central corneal thickness should be more than 300 microns, or it has to be after, like residual bed thickness should be half of the corneal thickness. Contact lens free period should be 3 to 4 weeks for rigid contact lens and 2 weeks for soft contact lens.
So this is something about ablation. So we are just coming to small calculations as we go through. So we saw the keratometry 40, 47. Then the other thing we need to look at, when we also need to look at how much of ablation happens with each diopter of correction. So this is what happens in the excimer laser. So you can cornea fellows tell what are the layers or the nomenclature used in excimer laser? What are the layers of ablation? Can anyone tell? There are different zones when you ablate the cornea. So you have one is called ablation depth. The second is, so the first one is optical zone. So that is the area through which the patient is going to refract and see through. Okay. So you need to know about how much is the optical zone. Then ablation zone, there is something else in between. Transition zone. So we can't make the entire cornea flat. You can't make the entire cornea steep. So we need to have a transition so that it is smooth. Okay. So that there are no undue aberrations which are caused. Okay. So depending on the zone, the amount of ablation varies. So this is the formula that they use to know how much is the ablation. Okay. So the aim of all the refractive surgery procedures is to keep as much of residual bed thickness. We are not disturbing much. At the same time, we are not trying to you have to control, give the best quality vision to the patient. Okay. So So go ahead. So if the ablation, when the optical zone is small, the amount of ablation is less. The optical zone is more, you have to ablate more. Okay. So these are things which you keep in mind. So let us go back when we go for calculations.
Muller-Lane equation defines the depth of ablation that is required to achieve specific amount of correction. It is T is equal to S squared D by 3, where T is the thickness of tissue ablated in microns, S is the diopter of optical zone in millimeters, D is the dioptric correction. This is the chart which shows the amount of ablation and the correction.
So just go. So we are correcting both sphere and cylinder together. Higher. So there is a chart we can quickly refer through. So you can have a reference chart in your uh, clinic, and then you can just cross check and see how much is the ablation. You need not go back and look into it. A very simple way to remember is every diopter of ablation, you will have minimum of 12 to 15 microns of ablation depth for each diopter of correction. When you have a cylinder, you can actually club them together. So here, like for example, you have -4 with -2 cylinder. So how will you calculate what is the refractive error that you are going to ablate? No,
We calculate -6.
yes. So we'll not be calculating spherical equivalent here because we want to save as much of the tissue. Okay, so we calculate it as -6 and then multiply it with per diopter so that we are on the safer side. Okay, so we try to keep a residual bed thickness more for each of the patient. Why? Why do we want to keep a good residual bed thickness? First years you doubts you can clarify anytime. Okay, so that's the reason we want to take it very low. Okay, why do you want to keep the minimal corneal thickness at the end of the procedure? If the cornea is very thin, what will happen? What is?
Prevent ectasia.
Okay, so this is iatrogenic ectasias. So iatrogenic ectasia, you are creating the cornea thin. So because of intraocular pressure, because of various forces, the cornea tends to thin out. Okay, so this is called post LASIK ectasia or post refractive surgery ectasias. Okay, most commonly it is post LASIK because the residual bed thickness goes very small. Okay, whereas Epi-LASIK we try to preserve as much as more than 350. Correct? Fine.
Moving on to SMILE. Here we use a femtosecond laser for 4 sequential photoablative incisions are made, and intrastomal lenticule is created and a corneal incision that extends to the anterior surface of the lenticule. Indications for SMILE includes refractive error of -0.5 to -12 diopters. Age should be more than 18 years. Mesopic pupil size should be less than 7 mm. Residual stromal bed should be more than 250 microns. Central corneal thickness should be more than 475 microns. Stability of refraction should be maintained for 1 year. Keratometry here, more than 35D and less than 47D can be tried.
Yeah. Anybody, once you can tell what are the various cuts happens in smile. So it is again the same procedure where you are not using ablation. It is only you are cutting the cornea and removing a lenticule so that there is no second laser required. So entire thing is done by a femtosecond laser. So the lenticule is removed so that the cornea becomes flattened. So what are the cuts you have? Any idea? No. So how does the laser cut? Does it cut first? What are the different? How many of you seen smile? Okay, the posterior. Then before anterior, you have to remove a lenticule. No, so you cut inside. Okay.
Bed cut
Mm-hmm.
and
What is that called? Cap cut. And
then
then
the corneal incision
yeah.
hinge.
So that can go ahead. So you have the 3 cuts. Okay. So this is a spiral laser. So the first the spiral lasers from spiral in to in. Then you have the side cuts. Then the spiral out, and then the final is the cap opening incision. So that then you go and separate these layers and remove them. So this is what is smile. Okay. So now we saw the PRK, we saw LASIK, we saw microkeratome based femtosecond laser and smile. So these are the options you have when a patient comes to you.
Advantages of SMILES include provides better biomechanical stability for cornea. No flap related complications will be here. It is suitable for thin corneas also. Fewer higher order aberrations will be here in SMILE. Moving on to LASIK, it creates an epithelial flap with dilute alcohol applied for 25 to 35 seconds, and repositioning of the flap happens here. The plane of cleavage is hemidesmosomal attachments in the superficial part of lamina lucida of basement membrane. Moving on to Epi-LASIK. Epi-LASIK, here epithelial keratome is used to lift the epithelial flap of about 50 microns. 50 microns of epithelium is removed. Here the plane of cleavage is not within but underneath the basement membrane. Advantages over LASIK include flap-related complications are eliminated here. Absence of corneal lamellar flap, so it reduces the risk for keratectasia.
So those are the procedures we have. Then we also need to know what are the type of lasers which are used. So what is the laser which we have at Shankanetralaya? Anyone? Any second years? What type of excimer laser? The name of the laser? It's a wave light, Alacrito wave light excimer laser. So it's called. So based on the wavelength, it is labeled as EX500. So we are not going to deep depth of the laser part of it. We'll come back that on a different class. So more we can evaluate on how to evaluate the patient and how to suggest what laser to go ahead. So then we also have very quickly we can look into what are the types of ablations which are there. So there are conventional ablation procedures, wavefront optimized, wavefront guided ablations. You can go ahead.
In conventional ablation, it treats only the lower order abrasions such as myopia, hyperopia, and astigmatism. It may induce more higher order abrasions like spherical abrasions and comma abrasions. Wavefront optimized ablation does not include new higher order abrasions. It does not address pre-existing higher order abrasions. Wavefront guided ablation or customized ablation, it addresses both lower order abrasions and higher order abrasions. It is not suitable for patients with multifocal IOL, small pupil, and irregular corneas.
Yeah, there is wavefront optimizers. Basically, as I said, we have the three zones: optical zone, transition zone, and the ablation zone. So we don't want to induce high order abrasions. So that is the reason why it is called wavefront optimized, so that we don't have the spherical abrasions which are created because of the laser. Whereas in wavefront optimized, it is customized to the patient. So we do a wavefront map, wavefront, and then use it. So there is one more which is, so and what type of laser is it? What type of laser beam it is? The current latest advanced laser procedure uses what type of laser beam? It's any fellows? So what is the first laser, initial laser when it came into existence? Yeah, it's a broad beam. Okay, the entire laser is as a single beam it was delivered. Now it is so fine and they are flying spots. So they are at this rate is very high. That is the 500 hertz. So that's the reason why we use at different. The spot size is very small, so that you don't. So when we have a spot size is very small and it's flying spot, we can create a zones at different. Whereas in broad beam laser also we used to have different. Uh, uh, something like obstructing it so that we create a multiple zones in that also. Okay, so go ahead.
Moving on to topography guided ablation. Here, the treatment is linked to the corneal topography rather than the total wavefront data. It is used to treat pre-existing corneal irregularities, small or decentered optical zone, and LASIK flap-related complications.
So there is, when we use topography related information along with the refractive error, that is called topo-guided treatment. So what is the example of it? Okay. We can also use in myopia refractive error. So what is it called? Anyone? What is the name of the procedure?
Contour lasers.
Yeah, it's a contour laser where they use the topo-guided information along with the refractive error so that it is more customized. Okay. So whereas when we use a wavefront aberration, okay, then it is wavefront guided. When you use a topography information, it is a topo-guided ablation. Go ahead.
Moving on to conductive keratoplasty, here mild heat from the radio frequency waves is used to shrink collagen in the periphery of the cornea. This deepens the paracentral cornea. It is used for hyperopic corrections up to 1 to 2.25D and presbyopia. Here, conductive keratoplasty spots are applied within the probe in a ring with a diameter of 6, 7, or 8 millimeter. 8 spots are given in each diameter ring. The drawbacks of conductive keratoplasty are regression and retreatment is required in 100% cases after 6 months. It may induce cylinder up to 1 diopters. It is reported in many cases, usually done in one eye. Moving on to phakic
Radial keratotomy, conductive are all obsolete now because of the complications and the accuracy is less, so we don't go ahead with those procedures. But just for the sake of exams, you need to know them. Just at least to know the basics of it, how it is done. Okay, because they will ask you write an essay on refractive surgery procedures. So then you need to know the classifications and all of it, and then go through. Yeah.
Moving on to phakic IOLs. Here, the artificial lenses are implanted in the anterior or posterior chamber in the presence of natural crystalline lens to correct the refractive error. There are 3 types: anterior chamber angle fixated phakic IOL, iris supported phakic IOL, and posterior chamber phakic IOL. Criteria for implanting phakic IOL include age should be more than 18 years, stable refraction for 1 year, ametropia not suitable for eczema laser surgery, and anterior chamber depth should be more than 3 mm. Minimum endothelial cell density should be there, and no other ocular pathology should be noticed. Indications for phakic IOL include the types of phakic IOLs are discussed. High myopia, in case of high myopia, we can use Versace or artisan iris claw lens, which can correct myopia up to -5 to -20 D, astigmatism up to 2.5 diopters. Vision ICL implantable contact lens can be used in case of myopias -3 to -18 diopters, astigmatism up to 6 diopters. High hyperopia up to 3 diopters and can also be corrected with vision implantable contact lens.
Okay, what is ICL? Any first year, what is the full form of ICL?
Implantable contact lens.
Implantable contact lens. It is based on the material used. Second year? But now we have different materials also. So that's basically phakic IOLs. They are not called implantable contact lenses. Okay. There are materials like acrylic material also have come, which are of different brands. The first one was ICL. So they have used the Colama lens. Okay, that is the material which was used. So again, the range is, so they have a range up to 18 diopters. Again, you have to look into it. It's not -3 to 18. The sphere and cylinder put together should be less than 18. So it is, if it is more than 18 diopters of any of these power. So if you have -10 with -6 cylinder, yes, you can correct. The patient has 17 with -3 cylinder. What will happen? How much can you do ICL? -17 with -3. Okay, -3. You can correct only up to 18. So what will you do? So you have to go for 18. If the patient is happy with -2 uncorrected error, fine. Otherwise, you have to go for a laser-based combination. Okay.
Contraindications for phakic IOLs include myopia other than axial myopia, corneal dystrophy or endothelial cell count less than 2000, anterior chamber depth less than 3 mm, history of uveitis, presence of anterior posterior synapse, glaucoma or IOP more than 20, evidence of nuclear sclerosis or developing cataract, personal or family history of retinal detachment, and diabetes mellitus.
So these are very important. You need to look into all these things. Just go back. So the most important thing is, so what is the most important parameter you look when you are planning for phakic IOLs? So anterior chamber depth. Okay, if your anterior chamber depth is not good, what will happen? So you'll have synapse formation in the periphery, and you are close to the endothelium. So there can be a damage to the endothelium and all that. Okay. So 3 mm is the minimum cutoff. So whenever you're excluding, so the first set is spectacles, then you have contact lens, then laser-based procedures, then you come to ICL. So this is in the gradation you need to talk to the patient. The patient will say, I want ICL. You will have a power of 5. But when the patient is eligible for refractive surgery, should opt them. Okay. So that you have to give them the options which are more safer and more uh, comfortable for him. Okay, safety is what you need to look into it. Okay, here it is an intraocular procedure. Whenever it is an intraocular procedure, what is happening? You are opening the eye, so you are allowing some infection to occur in your. We don't know what will happen to the dynamics of anterior chamber. When the anterior chamber is opened up, there may be fluctuations. They can cause contraction in the vitreous. They can cause a pull in the on the retina because of the vitreous contraction, develop retinal breaks, holes. Okay, and these are patients with high myopia already. Okay, they may have pre-existing lesions which you would have missed, and you can lead to exposing the patient to higher risk. Okay, so this risk is also there in other procedures, but they are much reduced when it is a closed chamber. Again, in LASIK, we are what is happening? We are increasing the pressure of the eye. Okay, and then only we are creating the flap. So there is a transient increase in the pressure and sudden release of the pressure because of the vacuum. So that can also cause the changes in the vitreous, that can also pull the vitreous and cause breaks and all that. So we have to examine the fundus in detail. Okay.
Advantages of Phakic IOLs over laser corrective procedures include a high range of refractive errors can be corrected, and it is a reversible procedure. And here, no structural changes are induced, and better quality of vision is there. And it is a highly skilled procedure. It prevents misuse of procedure. Moving on to bioptics, it is a combination of phakic IOL and LASIK. Bioptics is done for the correction of residual spherocylindrical power, where a spherical implant is used.
So with all these in options, we'll go ahead with preoperative evaluation. We go step by step. So when a patient comes to you, how will you evaluate? So these are the common questions which they will ask. They will ask you about classification of the various refractive surgery procedures and how do you evaluate. I think we got this question in our DNB. Okay, so this is the most common question. So you need to know how to evaluate a patient when a patient comes for refractive surgery, and this is day in and day out which you will be dealing it with patient when they come to you. Okay, so pay attention. We'll try and address all the points. Okay, let's see. Go ahead.
So here, age of the patient should be minimum of 18 years.
Yeah,
Gender
so let's start with why should be age minimum. So scientifically, we need to keep looking at it. Okay, why age minimum of 18 years? First years again.
Till then, the eye can, I mean, beyond that, the eye stops growing. So the change in refractive power will not.
Okay, so you need to look at myopia progression. So when does the myopia progression stops? So usually when you have at the adolescent age, usually it is around 18 years. So you need to make sure that is not just because the patient has become major that you are going ahead and doing the treatment. That may be also one of the point. Okay, they are giving consent and then you are going ahead with the procedure. But most important is the myopia progression stops before 18 years. And if still the refractive error is changing, you are not supposed to do it. So the minimum criteria, we need to look at the age. Many of the patients, when they come to you, the demographics has to be counter checked. Ask them for date of birth, check for this. Many of them just would give you a wrong date of birth just to get the procedure done. Okay, so you need to be very cautious about it. Guide, tell the patients, because they want, having come, they want to finish the procedure, they would give a wrong age and go ahead. Okay. The second one is gender. What is the importance of gender? Yeah. So again, the importance is the hormonal imbalance. So it can cause lot of the healing mechanisms are affected when there is a hormonal imbalance or there is a fluctuations in hormones. When does the hormone fluctuation occurs? Most common ones, physiological. Okay, so we need to always look at physiological. Patient, when does the patient comes for refractive surgery? Most common, when does they come? So before marriage. Okay, so we have to caution. So this is very practical. Okay, what happens? They come and they become pregnant after laser, and if you are not cautioned that there is going to be a fluctuation in the hormones, and that can cause, it can affect their, so regression, the power can come back. Okay, so you have to caution them. That's the most important thing. So the physiological part of it is very. So what is minimum period we suggest? 6 months. And for lactation, when do we do, if they are lactating, they have a baby, and before, after stopping lactation for minimum of 3 months. Okay, that's the time when the hormones become to normal level. So that's the time when you can go ahead with the procedure. So you have to ask these questions. That's the thing why we are putting on the agenda. Okay. The second important, why do the patient wants to go for laser? What are the most commonest causes? We have just saw cosmesis is one of the most important thing. Profession. Okay. What kind of professions require people go for it?
Police, military, navies, where
Okay.
they want a 6/6 vision without glasses.
Okay. Why do they want 6/6 vision without glasses in police, navy? Because they are.
Trauma.
Why does they need it? Simple. Again,
Field
common
work,
question.
in field work, glasses can lead to trauma.
Imagine in military you're wearing glasses. Okay, the enemy is in front of you. Your glasses is broken. Very simple, correct? He will shoot you. You can't see him. They can see you. Okay. The same thing happens with the police. Okay. So that's the reason they want. And the other one more profession which is more important, where the people come for it.
Pilots also.
Pilots. Okay. One important category of people who come for it.
Athletes.
Actors, that's for cosmesis. I'm looking from the professional point of view. Athletes, again, that is fine. The most other important one in the mic. If you have been in LASIK OPD, the patient says, "Sir, I have come for it, and without this, I will not get qualified for the job."
Government enrollments.
Okay, one is government enrollment. They have to have a power less than no, they can have 6/9, but they should have a refractive error less than. The most of them they have less than 5 is okay. They are acceptable, and they should have at least 6/9 vision. But one most important one, yeah, somebody.
Seafarers.
Sea sailors. Why? Again, common sense.
They cannot swim with the glasses.
Swim.
They cannot see.
Their boat or the ship is drowning and they have to swim. Their glasses have gone. They can't see they may be swimming on the opposite direction. Correct? Very simple. So that's the reason the marine engineering, the people who have courses in marine engineering, they want to have unaided vision of 6/6. Okay. So these are some of the indications which the patient comes to you. Okay. Apart from athletes, military, and other occupations. So this was actually one of the theses of one of my DNB student who looked into all the patients who underwent LASIK to find out why did they underwent what were the problems they have and the reason why they underwent the procedure. So they developed a qualitative research. This was a qualitative research study. So they did what is called a focus group interviews. So they have 10 people, they ask them what are the problems they have with the glasses, what are the problems they have with contact lens. These are the questions. So many of them say face problems in finding a match for them. Okay. So interpersonal relation problems, taking help from others, restrict their hobby activities, worsening of refractive error. They're concerned about their eyesight because the power is keep on increasing. That may be their perception. Then others are professional related problems, concerns of career appearance, interpersonal relations in the job, self-confidence, difficulty in meeting clients and customers, limit the ability to work for long hours with a contact lens, difficulty in sports like swimming, boxing, gymnastics. So one important thing related with swimming, anybody can, as I said, with contact lens, many of them would be using contact lens and many of them ask because some of the reasons why the patient ask why they don't want, they will come for laser is they don't want to wear, they are not able to swim. Okay. So what option can you give them? They don't want to go for procedure, but they want to swim. So do they have an option? Yeah, so you can have a goggles with the refractive error on them. Okay, so you can provide them that option in spite, so they can try that. In spite of that, they are not happy, then they can come for the procedures. Okay, so you have to have those options. Then they also complaints of glare, double vision, limitation of field of vision. So with the spectacles, very high refractive error, they have a difficulty in the field of vision. Okay. So again, the other complaint they say is when they remove the glass, they cannot see. Okay. Most of the time when they have thick glasses, you would have seen in all the films, no? What they have, thick glasses and they can't see and the villain comes and all that, no? They will be, so that's the most important. This is the day-to-day problems they have. Okay. As soon as I get up, I have to search for my glasses. That is the common problem which they say. Okay, all these are some of the things like not able to find stairs down at night. So these are small things which they have put it up. Okay, go ahead with the next. Then we ask them what are the reasons why they have. So many of them gave. So why did you go for glass? Because of the heaviness of spectacles. Okay. Second one is field of vision. Then the commonest cause they say is they have a pigmentation over the nose. Okay. So these are the actual real questionnaires which we ask based on the focus group interviews. So that is called as qualitative research. We select 10 patients and ask them to discuss why they need to go for a refractive surgery. And then we come out with all the questions. And the most common questions are taken it and then that are validated. And then that is how we go ahead and develop a qualitative research questionnaires. Okay. Some have complaints of glare. Again, the problem with the glare with the glasses is because they don't maintain the glasses, so they have a lot of scratches. That's the reason why they have that. They have double vision. Okay, frequent dropping and breaking of glass, so they don't have a second pair of glass. So if they frequently break them, that was the reason why they give, or misplacing or forgetting to carry the spectacles, and very few had non-specific reasons. Okay. And with contact lens, they had with most commonly they have irritation and dryness. They're not able to wear the contact lens for long hours. These are the some of the questions for the reasons why the patient wanted. So all these patients underwent laser. Okay. So just before laser, we gave them, and these are the answers which they gave. Okay. Go ahead.
Moving on to ocular history, spectacle or contact lens use should be asked for. Stability of refraction of it should not be more than 0.5 D difference. And contact lens history is important. Here, contact lens may induce corneal warpage. Can anyone tell me what is corneal warpage?
How many of you use contact lens? So what is corneal warpage? These are simple things which why should we discontinue contact lens? The first thing is we looked at the stability of refraction. We'll come back to that again. So what is corneal warpage?
It's a irregularity in the epithelium, as in the tear film instability occurs there, and a dry spot kind of a thing. Epithelial irregularity occurs after the using of contact lenses, so that can be picked up on top of that.
Why does that occur? The simple thing, you wear a cap every time, okay, and remove your cap. So what happens to your hair? It get disfigured, no? Okay, so it will take the shape of the cap. So what happens with the cornea? When there is a pressure using RGP lens or soft lens, there's a pressure on the epithelium, there will be some changes in the contour of the cornea. Okay, so that can induce steepening and various changes. So that's the reason we call it a corneal warpage. Okay, so that area of steepening or irregularity which is there in the cornea on constant wear of contact lens for more use. So it can be due to the soft lens or RGP lens. So RGP lens are more rigid, so it induces more warpage than the soft lenses. So when the patient is using contact lens, we need to ask them to stop the lenses before they go for evaluation of for refractive surgery. Okay, because if they come and they do not tell us and there is an irregularity or anything which we we may have to the patient may not be eligible for the procedure. So that's why we need to discontinue. Or if sometimes it can cause what does other things can cause because of corneal contact lens. Why should they continue contact? What does contact cause? When we wear a contact lens, what is changes occurring in the tear film? Simple. How does the anybody? I think we had a class 2-3 weeks back on contact lens, different types of contact lens, some value for a contact lens and all that. Forgot.
The oxygen permeability is
Yeah.
changes.
So what happens when the oxygen is not proper? What will happen? Hypoxia. Hypoxia can cause some metabolic changes in epithelium. So when there are metabolic changes in epithelium, what can happen? There can be a swelling in the epithelium layers or in, so which will give you a false reading of your pachymetry values. Okay, so that's the reason why we need to discontinue contact lens also. So when you do a study to find out how much is the change in the epithelial the central corneal thickness before and after use of contact lens, there was almost 5 to 10 micron difference. Okay, so the aim is we need to have an accurate measurement, which is a constant value. Okay, because when you are ablating, when they are in the borderline values, you have to discontinue. So we'll come back on to all the pachymetry related information. So contact lens is very important. So they have to discontinue so that they have a no warpage, there's no hypoxia, so there's no induced thickness, increase in the thickness of the corneal thickness. Okay. Coming on to the refraction, so the most important is it should be stable refraction. The second is, have you all done objective and subjective refractions? Okay, there should not be any difference in the objective and subjective refraction. What is the way in which people? You have it in the next slide. Okay, so I'll just will.
General medical history like diabetes mellitus, autoimmune disorders, these two may delay wound healing. Pregnancy, breastfeeding, thyroid eye disease, seizure disorder, immunodeficient states, and history of medication should be asked. Especially OCP usage should be asked because it may cause dry eye. And use of isotretinoin, beta blockers, steroids, tricyclic antidepressants should also be focused on.
So diabetes is not a contraindication. Okay, if they have a good control of diabetes, you can still go ahead with the refractive surgery procedures. Okay, collagen vascular diseases, yes, it is a contraindication. Absolutely, you should not have any connective tissue disorders. What other important question you will ask about when you are doing any surgery in the eye? That's surgery. What is all these surgery causes? It is basically burning some tissue. So when there is a burn, how does it heal? Huh? Yeah, it heals by scarring, correct? The scar is microscopic. You can't really make out. So the people see it is still, it has to heal. Okay. The healing is so fine. The scar is almost the fibroblast and all that, not badly affected. So you don't have a very bad cornea. Okay. So that's the reason. So if we use mitomycin and also very smooth procedures. So if a patient has history of keloids, you should not go for the procedure. Okay. Whereas the thyroid, yes, you can still go ahead if it is under control. Diabetes, again, under very good control. But if the family, like we need to look at insulin dependent diabetes mellitus. So we have to counsel them very uh, properly that if they are not under proper control, they are prone for developing retinopathy and all the other things. So we have to be very careful. But still, if a patient insists, you can go ahead and with the procedures. Yeah.
Moving on to ocular examination, here visual acuity and refraction should be done. Best corrected visual acuity and undercorrected unaided visual acuity should also be taken off. Here, best vision with least minus is the goal for refractive surgery. Duochrome test should be avoided because it may result in over minus. Both manifest and cycloplegic refraction is important. Prism should be noted if anything is there. And ocular alignment, we can make out ocular alignment using Hirschberg's test or extraocular movements or cover test because asymptomatic tropia or phoria may break down following surgery due to change in refraction.
Okay, so one important is we need to look at subjective refraction. So first is objective refraction. Objective is what? What is first years? What is objective refraction? What is objective refraction? Should be pretty duck. Should not think of it. It could be retinoscopy or auto-ref. So which you rely on? Because auto-ref, there will be fluctuation. It will only give you the value what it is at that particular point of time. So you don't have a control because the patient has to focus at a distance object when they are measuring auto-ref. Unfortunately, everything is closed. Okay. So when the focus is, they may be using some accommodation and all that. So that's the reason you should always look at retinoscopy because retinoscopy are always focused at distant object and then you do the value. So the objective and subjective refraction should match. Okay. If it is too much of difference, that means patient is using some accommodation and all that. So it needs to be taken care. The patient needs to go for orthoptics. Whenever there is a difference between objective and subjective refraction is very high, so you have to get an orthoptic evaluation done and then go ahead with the procedure once they are stable refraction. Coming on to ocular alignment, this is very important. How do you test? Again, let us ask second years who is there who didn't answer. Sorry. Ocular alignment asymptomatic. How will you test for this? And what kind of assessment will you do to check whether this is fine or not treatment?
The Hirschberg test, cover uncover test.
Okay. But the patient has, okay, but it is not manifesting all the time. Fine. And the patient has refractive error. So patient has to go through and find out how much is the control of atropia, whether they will break down, the foria is breaking down, where the patient has more exotropia after the procedure or not. How can you test? Can they have some kind of a trial with something with glasses or something?
Prism.
Prisms, no. Give them contact lens. Simple. So when they wear contact lens, it is like the power is getting correct. And if the with the contact lens there is no breakdown in the 4 years, that means post surgery they won't be breakdown. Okay, so they can go for a contact lens trial and reassess the the ocular alignment with the contact lens and see with the patient wearing it for few hours, and if they are comfortable, then you can go ahead. Okay.
External examination here, recessed globe, narrow palpebral fissure, large nose, and prominent eyebrows are important to be noted because flap-based procedures are difficult in these patients. Here, surface ablation procedure can be preferred.
So again, this is very subjective. We can just do a trial run. Okay, take the patient to the LASIK theater, make him lie down and see whether there are any obstruction. We still do little modifications. We can tilt the head of the patient and then do that. But some scenarios they may not be possible. Then we need to go for a different procedure. That's very rare contraindication. Yeah. Go ahead, ma. I think we'll just run fast because then we have a case series to go through. Yeah.
Pupillary size plays an important role here because it determines the size of ablation zone. Large mesopic pupil size more than 8 mm is associated with post-operative glare and halos at night.
So what is the importance of people? So we are coming at with one measurement. So we are going to see in a case sheet all these measurements. So we call it mesopic pupil is ideal. We also call it scotopic pupil. So what is scotopic and mesopic pupils? What is the size of the pupil in different lighting conditions? Okay, scotopic is in dark, whereas mesopic is medium light. Okay, so why does the pupil dilates in dark? That's a basic physiological, correct? If the pupil dilates more, what will happen? Your zone of ablation is only to the optical zone. The patient will see through the optical zone. The pupil dilates more than the optical zone. What will happen? There are light rays entering through the optical zone and the transition zone. So what will happen? They will interfere, okay, and that will cause glare. So that is the most commonest complaint with the patient when they come to it. So I will end of the class. I will just tell how I counsel the patient. Okay, based on all these things, I'll just tell 2 minutes. I'll take and imagine you are the patient. I'll be counseling you. So these are things which the patient should understand and then go ahead with the procedure. So we have to talk about the pupil size also. So imagine this is a patient who have scotopic pupil is 7, okay, and you are treating this patient. Unfortunately, you have to have residual bed thickness to be taken care. I have to reduce the optical zone. Then I have to tell them you may have higher chance of glare. Are you willing to go ahead? You have to sacrifice on night driving, all those things. Yes, when the patient says yes, you go ahead. Tomorrow, when you have conveyed all these information, to the patient will be satisfied and he is taking a decision based on his knowledge, and he identifies what is the risk for him and then go ahead. Okay, otherwise he will come back to you and you will be having an unhappy patient. You will not be able to handle that scenarios. Okay, go ahead.
Slit lamp examination, here tear film has to be evaluated first. Schimmer's test, tear meniscus height and tear film breakup time to rule out dry eye. And in slit lamp, we have to rule out the signs of inflammation, infection, or any source of infection. So we have to look for blepharitis, meibomitis. Corneal surface abnormalities should also be looked for. Cataract, if any early lens changes are there. Tonometry and gonioscopy has to be done, and we have to look for any signs of inflammation.
Okay, first, yes. Why the dry eye is important? Why should we do all the dry eye evaluation? Very basic question. What happens with all these treatments?
During while making the flap for any procedure, there will be corneal nerves that will be cut. So that will lead to decreased lacrimation.
So what does it cause? Transient. There is a loss of sensation. How does the reflex of your blink reflex occurs? Can anybody tell what is the pathway of blink reflex? How does the blink reflex is induced and how the blink occurs? These are basic questions which you will get in your Viva. Okay. I don't know whether you have Vivas. Do you still have Viva in DNB? MS you have, no? DNB? So very simple. What is the blink reflex? First years, physiology, all that you should be. How does the blink start? When does the blink reflex? When does the initial afferent pathways? Nobody knows. Important. Just go and read about it. How does the blink starts? Whenever there is a first dry spot occurs, the nerves are stimulated. Okay. So once the nerves are stimulated, the impulse goes to the blink center and then that induces the blink to occur. So when there is no nerves, the nerves are not functioning, there is no afferent path. Afferent pathway is cut off. So patient will not blink. They will be keeping the eyes open for longer time than the normal. So what happens? They will be dry. Okay. So they will blink only when there is a stimulus of pain. Okay. Because that is how the pain will. So that's the reason why they won't blink normally. Correct. So the blink rate will be reduced. So when there is a blink rate, because tear film disturbance, what happens when there is a tear film is disturbed? Does tear film contribute to something? Clarity of vision. Okay. So when the tear film is disturbed, your clarity of vision is lost. Okay. Patient will say, each time I blink and open my eyes, the vision is becomes clear and again it becomes blurred. So this is what the patient complains after surgery. Then you have to tell them this is because of the transient process. When the nerves regenerate, you will regain the sensation and then you will be able to see well. So at each of these procedures, the amount of nerves that are damaged. So with Epi-LASIK, it's almost 360 degrees. Whereas with femtolasic, you have about 60, uh, uh, 60 degrees to 80 degrees because of the hinge is protected. The rest of it, like maybe I'm not exact measurements is different with the different hinges. So at least 270 degrees of nerves are damaged. Whereas in femto, it is less. It's only like 60 degrees are damaged, the rest of it is preserved. Okay. So these are the three things which you need to look into and ask the patient. So tell them there is a people who are working on computers for long hours, they will feel the dryness is more. Okay. Because the blink reduces with when they are staring at particular object for a longer time. So which is basically the important cause for computer vision syndrome. So when now if they do laser, what will happen? They're already reduced, then this also adds on, so which becomes more complex. Okay. So you have to tell them you have to blink voluntarily, you have to use the drops until the nerves regrow. So there are a lot of studies on how the regeneration of the nerves occur and what kind of nerves, how does the end, the nerve endings, how does they come back and how does they function, all that there are plenty of studies available. So at least the basics you need to keep in mind. So to assess that, you need to have all the dry eye related information. Then you should not miss on blepharitis and myomitis. Then other things are corneal abnormalities. Many of these patients who are using contact lens will have, if they are not properly following the regime, what will they develop? Contact lens induced keratitis, which could be microbial keratitis or it is just sterile infections, inflammation infections. So which can really lead to scars. Okay. When there are scars, what happens? When I do a laser, what will happen? The area under the scar, the laser may not penetrate well over the scar. Okay. So like if I doing a femto laser or smile, there should not be any scars because there are chances the laser may give way. There is some, it will be opening up through the scar and come out, and that can also be a problem. And the area where the scar is there, the ablation may not occur properly and you will not be able to separate. So that's why we need to keep a eye on the scar. Okay. The contraindicated for dystrophies, ectasia, completely contraindicated. The most important thing, all patients you need to dilate and see them, because they should not have any lens changes. If they have a lens changes, that is the most contraindication for laser based procedures or even phakic IOLs. So we have looked into it. So there should not be any cataract or any sign of cataract. Patient with high myopia, what type of cataract they will have? Yes, they will have a PSC cataract. Okay, so if they have an even small component of PSC cataract, watch them. You can tell them this cataract, you may develop cataract at a early age. Okay, so the benefit of your refractive surgery is for shorter period of time, and if you develop cataract, there will be, you have to go for a cataract surgery. So we will make sure the lens is absolutely clear. Then we also need to look at whether the lens is inducing myopia or astigmatism. There's a lens induced astigmatism because of various, because of there may be zonular disturbance or something. So that also you need to keep in mind. Okay. Others are simple. Yeah, go ahead. Okay. I think just 5 minutes we'll wind up. The most important thing are the answers.
The ancillary tests here, pachymetry and keratometry are the most important tests. Corneal topography and tomography, it is not done in all the patients. It is done to look for keratoconus, pellucid marginal degeneration, contact lens warpage, and amount and axis of the
It's done in
astigmatism.
all patients. Tomography is the gold standard which we do for all patients before the refractive surgery. Yeah.
Finally, we have to do a detailed fundus examination to look for any missed lattices or.
Okay, so now this is all calculations. We'll just spend 5 minutes on these calculations, and then when we evaluate the patients, what are the various calculations you need to keep in mind? You can just keep a paper and you can make a note of it, and then we can work out on it. Okay. So the first and foremost is the pachymetry. Okay, so the first thing is numbers. Related with numbers, what is the first thing? Age. You check on the age. Second is stable refraction. So all the values of refraction we are cross verified. We are checking with the PGP. We are checking with objective refraction. We are checking with subjective refraction. There is no change. Everything is fine. Then you come to corneal thickness. Okay. And corneal thickness, again, without use of contact lens, you have to get that. So what we looked at is the minimum corneal thickness, if you have to go for laser based procedure, should be less than, it should not be less than 470 microns. Okay.
Residual bed thickness has to be it is equal to pre-op central corneal thickness minus flap thickness plus depth of ablation.
Yeah, go ahead. Yeah. So go ahead with the next one, then we'll ask the question. So just keep this in mind. So if you know this, so then you can put the patient in each of them category. Okay. So pachymetry, so you have less than 470, no laser based procedures. So what are the procedures available? ICL or clear lens extraction or contact lens only. Okay, so always keep contact lens as one option. Patient will forget, they have not used contact lens at all. Okay, give them that first option. Let them go for a trial, come back, use them for 2-3 months. Once they are comfortable, well and good. Because most of them only want for social functions. Okay, and that is the best option. They can use it whenever they go out, and rest of the time they can wear the glasses, and they'll be most happy, and they don't need to go for a surgery. They're not exposed to any risk. Okay.
In case of 470 to 500 microns, photorefractive keratectomy or Epi-LASIK can be done. More than 500 microns, Epi-LASIK, LASIK and SMILE can be done.
Okay, just go back. So anything more than 470, Epi-LASIK. Even if it's 550, 600, you can do Epi-LASIK. Don't think Epi-LASIK should be done only for low refractive errors. It can be done for any thickness of the cornea. Okay, whereas SMILE and LASIK is indicated only if the corneal thickness is more than 500. You have to be safe. That's why we keep it at. There are some centers who do at little 475, 490, but the safety is more important. We always keep it at 500 microns. Okay. So that first, second,
Refraction. So less than 6 diopters can be corrected with Epi-LASIK, LASIK and SMILE. 6 to 12 diopters can be corrected with LASIK and SMILE. More than 12 diopters, we have to go for ICL.
so this is again the other cutoff you need to keep in mind. Why can't we do Epi-LASIK more than 6 diopters? So there is something called PRK haze, okay? So which you need to know. So all these we look into in the complication in a separate class. Okay, PRK haze, that's why we use mitomycin. Higher the ablation, that means more tissue is ablated, more the inflammation and all that, correct? In the healing process, so which can lead to haze. So up to 6 diopters, it is fine, okay? We can still do little more, but we have to balance it with steroids, mitomycin and all that. You can stretch them. That is in the borderline, so you don't need to worry about the borderline cases or the extremes of cases. Most common things you need to have, okay? The examiner won't ask you about the extremes, they will ask you the most common, okay? Fine. So then comes, so we had refraction, we had pachymetry, then comes your keratometry. So again, very, very important. We looked into it, okay? If it is flat cornea or steep cornea, you need to be cautious. Okay, less than 40, you can still do, but what happens at the end of it? Go ahead. So we need to identify what is the final keratometry value after the refractive surgery. So any cornea fan knows what is the refractive acceptable keratometry after refractive surgery. So you all come to consensus and tell me what is the ideal one. So you have to be safe. Always keep safe. Okay. Instead of going at extremes. Okay. So always try to aim for the safety. So keep it at 36. Okay. Ideally 36. Anything above 36. What happens when the cornea is too flat? You will not have that. There should be some kind of aberrations. Then only you have the good quality vision. If there is no aberrations, everything is flat, the rays of light is going parallel, they don't focus, then it is. So it's, so how do we calculate how much is going to be the final K after surgery? So every diopter of correction, there is a change in the K reading by 0.8 diopters. So this is an example. When a K is 44 at 180 and 43 at 90, so the average K, you can take the average K or the steep K. So ideally better is to be safe side, take average K. So how much is the diffraction we are correcting? 10 diopters. So the final K will be 35.5. So anything between 35 and 36, it's fine. Ideally try with 36, but when the range is high, you can go little 0.5 this way or that way.
Residual bed thickness, here in photorefractive keratectomy, it should not be less than 350 microns. In LASIK, it should be more than half of the central corneal thickness and should not be less than 300 microns. Percentage
Should be more than 300 microns.
should not be.
Should not be, okay, yeah.
Percentage of tissue ablation is calculated using the formula flap thickness plus ablation depth divided by central corneal thickness. It has to be less than 40%.
So these are various factors which we need to keep in mind because of to prevent ectasia. So they use what is called percentage tissue ablation. So we need to make sure it should be less than 40%. Okay. So we need to know this common things. What is the flap thickness in each of the procedures? So these are all, keep it in your mind so that when you do your calculations, all these will come in to picture. So femtosecond, we can have a flap thickness of 100 to 110 microns. Okay, so you can set it up between 100 and 110. With microkeratome, we can have different blades. So for 130, 140, 160, different blades, you can have the consistency will be more with femtosecond compared to microkeratome. Okay. We also need to know what is the results of it. So this is where we have comes with the nomogram. So when we plot, this is actually the results of our LASIK procedure done in maybe 5-6 years back of some 560 eyes. So we have what is the efficacy, what is the safety and stability of this refraction, how much is the correction happens. So you can see these values in D, okay? And we can also see how much is the cylinder, how much is the loss of lines happens with the treatment, how much of them gets corrected, and the equation, all these. And the last one you see how is stable at 1 month, 6 months, 1 year. If you plot them, is the refraction after treatment is stable for long. So we look at safety, efficacy, stability, accuracy, okay? All these are some of the terms which they use in laser procedures, okay? Just for you, I'm not going to in detail. Why do we talk all about this? So when I counsel the patient, I would say, when I do this procedure, I'll just talk exactly how I talk to the patient. I'll say, so imagine the patient has a power of -4 with -1 cylinder and has 520 microns thickness. So when the patient comes to you, I just review the case sheet, and this is how I speak to the patient. So I'll tell them, so when we do laser procedure, we cannot guarantee 100% always that you get zero power at the end of the procedure. We can assure you 95% your power will get corrected close to zero, or which will be like either 0.25, 0.5. That means 95% you will get a power which is 0, 0.25 or 0.5. And all that is based on the results. You can see in the paragraph D, okay? Sorry, in the graph D, no? So it says plus or minus 0.5 is 97%. So I'm saying to the patient, little less. I'm saying 95%, you'll get close to zero, which is less than 0.5. When I say less than 0.5, you are comfortable without glasses. If your power is more than 0.5, you may need to wear glasses. So these are the sentences I use. Okay, very rarely there will be 5% of people who will get a power more than 0.5, and you may need to wear glasses. That is the first statement based on the results. The second, I'll say 95% you will not have any problems in the quality of vision, but 5% of people may have problems with decrease in the sharpness, decrease in the contrast, glare at night, or halos around the lights. And these problems are not fully correctable, but you can get adapted over a period of time. Okay, these are the sentences which I use. So we can say these are, patient will get adapted to this problem, but they cannot be corrected. They will ask, can I correct them with glasses, sir? I said, this is not related with the refractive error. It is because of the healing process. So these are the sentence again you have to tell them. These are depends on the healing process. Why do I get power? When do I get power? These are the questions the patient will ask. You should say, we cannot predict that when you can get the power back. 95% you may not get the power. Even if it gets, it is 0.25 or 0.5. And when will you get? Cannot be predicted. The same thing, the symptoms I have said, it can be adapted over a period of time and you get used to it. Then you tell about dryness. I'll tell them there will be a transient dryness which will go off in the period of 4 to 6 months. So you have to keep in mind. Then I talk about, based on your pachymetry, based on your refractive error, you are eligible for Epi-LASIK, LASIK, femtolasic, SMILE, and I explain them what is each of the procedures. In Epi-LASIK, we just remove the epithelium. So you can tell the top layer, or you can, if it is a patient is very little illiterate, you can tell the skin is removed over the black portion of the eye. Then we do the laser, and once the laser is done, we put a contact lens. After 5 days, we remove the contact lens. Whereas in LASIK, we slice the cornea like a slicer, lift the flap, do the laser, and put the flap back. So there is a small risk, 1 in 1,000 cases, the cut may not be good. In such cases, we have to plan what is best for you at that time. The SMILE is where we only do the cut and we make a small opening, separate the cut and remove it. There's a small risk. Again, the cut may not be good if you move or do anything. And when we separating, there may be some issues. And this can happen in 1 in 100 cases or 1 in 1,000 cases. And then if you are willing to go ahead, then you go ahead with the procedure or for safety test. So we have not dealt with safety test here. Okay. There are series of tests we do with pentacam, specular microscopy, we have Corvus, all that, and then select the patient for the treatment. Okay. Go ahead. So this is, we have already discussed. Next. Okay.
Thank you, sir, for moderating the class. Thank you, Dr. Divya, for helping me with the presentation.
Good.